Yes, sir. Three, two, one, start.
A very good morning to all of you. Once again, welcome to the teaching class of Department of Urology, Savai Man Singh Medical College, Jaipur. Today, we have a presentation on Peyronie's disease. This will be presented by our resident, Dr. Rajeev Sharma, and will be moderated by our faculty, Dr. Manoj Bamaniya. So I would request Dr. Rajeev Sharma to kindly share his presentation.
Good morning, everybody. Good morning, respected teachers and my dear colleagues. Today's presentation is about evaluation and management of Peyronie's disease. Peyronie's disease, it's a disease of tunica albuginea where the abnormal wound healing process results in exuberant scar formation. The resulting scar or plaque formation is mostly inelastic, and there is the result is the penile deformity, which results in curvature, indentation, and hinge effect, and results in shortening. The prevalence is around 3 to 20%, and it occurs in two phases. The first phase is active phase, where the painful erection is the main symptom. The chronic phase, in the chronic phase, there is no painful erection. The caveats of Peyronie's disease, this is a rare disorder. There is no spontaneous resolution. All the age groups are affected. In the flaccid penis, the trauma is the main culprit for scar formation. The erectile dysfunction is a frequent sequelae. Plaque calcification is not an indication of a chronic phase disease. It can occur in an acute phase as well. The various associated conditions are seen when the patient is suffering from hypertension, hyperlipidemia, or low testosterone levels. In patients of diabetes, it's prevalent in 33% of cases. The erectile dysfunction is also more common in these patients. Various collagen disorders like doctrine contracture, this is also an associated condition in Peyronie's patients. The various psychological effects are the patient feels anxiety, loss of sexual confidence, and disgust. The penile shortening leads to emotional distress and relationship problems. Due to low testosterone level in patients of hyperthyroidism, there is more severity of Peyronie's disease. The impact of wound healing in the development of Peyronie's disease. In the acute phase, the blood vessel injury leads to extravasation of blood, which results in aggregation and activation of platelets. These platelets result in release of chemotactic agents, which attract various neutrophils that promote wound healing cascade and scar formation. Then the next phase is the proliferation phase. In this, the tissue repair, which starts after 72 hours of injury. The main driving factors in these are fibroblasts and myofibroblasts. Their migration in response to transforming growth factor 3 and platelet-derived growth factor results in execution of this phase. The last phase is the remodeling phase, which may last up to 1 to 2 years. This is regulated by mechanisms that balance the simultaneous degradation and synthesis of collagen and other extracellular matrix macromolecules. So any alteration in this process may lead to abnormal wound healing and excessive scar formation, resulting in Peyronie's disease. So this is the figure depicting the start of the then this penile trauma results in deposition of fibrin, and it results in attraction of inflammatory cells and platelets, which further attract after release of chemotactic agents the fibroblasts and myofibroblasts, and there is proliferation of these fibroblasts, which release further reactive oxygen species, which leads to activation of NFKB, and there is excessive production of collagen. This excessive collagen results in penile plaque formation, which is further calcified. The etiology, the proposed mechanism is in the erect state due to high pressures inside the penis. There is microfracture. which exceeds the elasticity and strength of tunica tissue. In the flaccid state of the penis, the trauma is the main driving factor. Other factors like genetic predisposition, autoimmune factors, and any aberration in local wound healing can result in Peyronie's disease. Fibrotic gene expression, three genes are basically involved in this process. The first are PTN or OSF1, which code for heparin binding protein. These are involved in growth of fibroblasts. The MCP1 gene is basically involved in inflammatory response and ossification. The symptoms of Peyronie's disease can be penile pain, erect deformity, palpable plaque, erectile dysfunction. Very torque pain is a very peculiar feature of patients with Peyronie's disease, which is associated with a pulling sensation. Physical examination. Basically, Kalemi classification is used for classification of the Peyronie's disease, which is around, in mild cases, 30 degrees, 39, in 40% of the patient, the Peyronie's disease patients have 30 degrees of curvature, and around 31 to around 35% of the patient have a curvature of 31 to 60 degrees, which is a moderate disease. And in 13.5% of the patients, the curvature is more than 60 degrees, and this is a severe Peyronie's disease. In 12% of the patients, there is an hourglass deformity, which results in unstable erection, and there is no curvature in this case. Other method of physical examination is for checking the severity of Peyronie's disease is stretched penile length. The Peyronie's disease plaque manifests as cords or bones, bone-like, or it can be an irregular dumbbell shaped. This figure shows the instability or the hinge effect of the erect penis in patients of Peyronie's disease. Peyronie's disease questionnaire, it consists of 15 components, where these can be grouped into three, where the first group is consists of 6 items revolving around the Peyronie's effects of Peyronie's disease on the psychological and psychological effects of the patients. In this second group, mainly it is addressing the penile pain, and in the third, the effects of Peyronie's disease symptoms can be seen. In the higher the score, the more negative is the impact on the patient. This is not very well visible. Otherwise, this is the questionnaire which is given to the patient to check the severity of Peyronie's disease. Then there is the role of duplex ultrasound. This duplex ultrasound helps in identification of calcification, and it is also useful in observing the erectile response to vasoactive injection. It also measures the peak systolic velocity and diastolic velocity. The measurement of erect penile deformity can be for curvature, girth, and any irregularities or hinge effect. In this figure, the penile plaque, there is a shadowing behind the penile plaque on duplex ultrasound. We come to management of Peyronie's disease. In this, reassurance is very essential for the patient, as there is more psychological effects. The various oral agents can be Petova, vitamin E, tamoxifen, colchicine, pentoxifylline, and PDE5 inhibitors. The intralesional agents of use for Peyronie's disease can be agents like verapamil, nicardipine, interferon alpha 2b, and clostridial collagenase. Among these, clostridial collagenase, it has the most effect, which results in decrease in penile curvature by 34%. The various external force applications for Peyronie's disease can be in the form of electromotic drug administration, extracorporeal shock wave therapy, penile traction, or vacuum therapy, or radiation therapy. Among these, penile traction is very effective, where there is increase in length by around 0.5 to 2 centimeter and increase in girth around 0.5 to 1 centimeter. Then we come to the surgical management of Peyronie's disease. Before addressing the Peyronie's disease through surgery, preoperative consent should be taken, where the set expectations about the disease and its outcome should be defined to the patient. The patient should be explained about the persistent or recurrent curvature. The goal is about functionally straight penis. The curvature of less than 20 degrees is the goal for the treatment. The change in the length, the result is more likely a shorter penis due to plication. And in case of grafting, is the modality if we use, then the penile length can be preserved. In patients, in case of diminished rigidity, which is seen in more than 5% of studies, grafting grafting is more than plication. 30% if the suboptimal preoperative rigidity is there. Decrease in sexual sensation is also it should be explained to the patient. The indications of surgery can be stable deformity for at least 6 months from the onset of symptoms. The inability to engage in satisfactory penetrative sexual intercourse because of deformity and inadequate rigidity. And the failed conservative treatment is also an indication for surgery. And for the patient who desire for their most rapid and reliable results, surgery is the main modality. So this is the algorithm for surgical management of Peyronie's disease. In patients with where the erection is adequate for penetration and with or without the help of PDE5 inhibitors, then duplex sonography is done, where if the curve is less than 60 degrees and the patient accepts the risk of length loss, then plication procedures are useful. And if the patient doesn't accept the risk of length loss, then plaque incision and partial excision and grafting can be done. In patients where the curvature is more than 60 to 70 degrees and the patient accepts the risk of erectile dysfunction, then plaque incision and partial excision and grafting can be done. And if the patient is not willing for accepting the erectile dysfunction risk, then penile prosthesis is the ultimately useful modality. In case the in case the erection is not adequate, even with the help of PDE5 inhibitors, then penile prosthesis is used, where the if functionally straight penis, if the penis is not functionally straight, then manual modeling is used. Surgical options can be like tunica shortening procedures, where the Nesbit procedure is used. It is done on the contralateral side of the curvature. This is the picture showing the Yachia procedure. In this, there is full thickness vertical incision, and the tunica albuginea contralateral to the area of greatest curvature is closed in a transverse fashion. This is the 4-dot procedure. The tunica albuginea plication procedure is seen in this picture, where two transverse parallel incisions are made. Then there are tunica lengthening procedures, where which is basically plaque incision or partial excision and grafting. The greater complexity of the disease, it is useful where there is greater complexity of the disease and where the curvature is more than 60 to 70 degrees and there is shaft narrowing or hinging effect. And also in patients with extensive plaque and calcification, tunica lengthening procedures are useful. And the prerequisite for this is strong preoperative erection. The graft material, ideal graft material is which approximates the strength of normal tunica albuginea, and it has minimal tissue reaction, and it is readily available, and it is pliable, easy to size and suture. It should be inexpensive and resistant to infections. It should preserve the erectile capacity of the patient. The two most commonly used graft materials are tutoplast, which is made up of pericardium of human and bovine nature, and small intestinal submucosa, which is of porcine nature. Post-op rehabilitation, telling the patient it is very essential to avoid the erectile dysfunction and length loss. It should be started around after 2 weeks of the surgery, and stretch therapy is the main modality. Nocturnal PDE5 inhibitors are very useful in this case. And use of various penile traction devices is also very helpful in post-op rehabilitation. So finally, the penile prosthesis, this figure shows the penile prosthesis, and it is indicated in patients with Peyronie'S disease, which is and if you have who have erectile dysfunction refractory to PDE5 inhibitors. So the various penile prostheses can be the one with the PDE5 inhibitors and the inflatable penile prosthesis, which is preferred surgical implant. Prolonged cylinder inflammation is recommended. Thank you.
Thank you, Rajeev. Dr. Sanjay, can you just unmute yourself? So I would request all our residents and faculty who have joined us, if they have any comments or queries, please go ahead. In the meantime, if Sanjay is there,
Good morning. Am I audible?
yeah, morning. Can you put on your video?
Yes, just give me a second. I'm actually.
We cannot see your nice face.
Good morning.
Yeah.
Good morning.
Good.
Very
Good morning. Good morning. Good morning, Sanjay. Yes.
Morning.
So, we are privileged to have Dr. Sanjay Pandey, who is a kind of internationally recognized urinary reconstructive surgeon. He is well known for his transnatal surgery, and he has a lot of interest in other areas like reconstructive urology and penile implants, robotic surgery, and Peyronie's also. So, Sanjay, you are most welcome to our teaching class. Thanks for joining it. And I would request your comments on the topic of Peyronie's. Yes.
Congratulations to Team SMS. I've been following this series very closely, and thank you, Rajeev, for making a very comprehensive kind of a discussion to start question answers, and probably keep in mind aspects of care on an individual with Peyronie's disease. We always say that we treat a disease. Out here in Peyronie's disease, sadly, we don't treat the disease. We treat the ill effects of the disease. In other words, one of the most disabling aspects of the mature individual who's more commonly diabetic, as very closely quoted in your series, is a gradual, progressive, defective change happening at the level of the corporal body, the tunica, which is visible to him initially with pain, agony, discomfort, which you take care of in the acute phase, and then it progresses towards a possible maturation. The maturation can take place, as rightly said by you, anything between 6 months to 2 years. But the initial phase of management is very important in confidence building of a pain that does not go with the basic analgesics, number one. Number two is, as you conquer the acute phase, there was always this thought that injectable therapies could actually divert the entire aspect of natural progress of change of this disease to a process where we could have lesser deformities. Now, that process probably is not so true, but in a set of individuals where you would be doing multiple injections could only add to sometimes more fibrosis. So injectable therapy, though, has been the benchmark of initial acute therapy. The acute oral therapies have been equally good, and they have been only helping him to phase out the acute phase much earlier. Coming to the aspect of care that you're looking at, of all the aspects that the patient complains of, which include, as you rightly said, the 5 important aspects, from the plaque to his erectile deformity. The difficult ones are, number one, mentally, the shrinkage of the shaft, which you would always believe is a mental issue or a psychological issue or a psychosomatic issue to the patient. But there is a gradual shrinkage of the shaft as the entire pliability of the tunica and the involved corporal bodies to sometimes go down, number one. Number two is the hourglass deformity, the hinge effect of which you rightly showed matters a lot, because hourglass deformity makes a huge difficulty in terms of the blood flow beyond a point in time. The two important practical aspects I would look at is one is a stable patient who says, my curvature is there. Obviously, everybody is born with a tilt. So if you have a curvature good enough that you can still penetrate with changes of postures after maturity. I suggest we always leave them alone, counsel them, keep watching them very closely. Some of them will probably be good for molding, but molding is always under anesthesia. So watch and wait is also a great way of counseling and confidence building on many patients with a lesser curvature and a lesser tilt. Individuals who have got a tilt and curvature, as rightly pointed out, of the kind which requires therapy, to still postpone it by attempting everything in the bed till they come and say that I'm morally lost. The individuals who have got erectile dysfunction are the ones who are in deep trouble. A progressive erectile dysfunction, a progressive curvature are the ones whose counseling becomes a big challenge. So as you rightly see, that individuals of this kind are in the prime of their life, losing a lot of their capability in the blood, a lot of their morale. They think about it 1,000 times a day and look at everything that's possible. Let's not forget we are dealing with a very sensate organ and one organ which is visible to a patient. I always say genitourinary medicine or our subject called urology as part of its organs inside the body and a part of the organs outside the body. Outside the body, a patient can know what you did on a frenuloplasty, on a circumcision, or a corporoplasty, or what you also call in the older terms called orthoplasty, straightening the penis. That was an older term in the Campbell's urology. So looking at all this, I think I personally feel that let's not say that we treat Peyronie's disease. What we do is we treat the ill effects of Peyronie's disease as required. It's exactly like BPH, where patient comes to you with his symptoms. It could only be some health checkup where you would find that some prostatomegaly is there. Similarly, here the patients may not complain very rarely of a change in his curvature, but majority of them are extremely bothered. So bothersomeness has to be brought down. As you rightly pointed out, the word counseling. Counseling is never a one day, 1 hour procedure. Counseling is a progressive procedure of mellowing down his expectations. He would expect it to be completely straight, and you would do it. When you do this incision and grafting called corporoplasty, you straighten the shaft completely, but then thereafter comes a huge amount of rehab work. The rehabilitation is important. The surgical cuts in the integument at the circumcortical incision, and as you went down and took layer by layer, all these have tendency to again fibrose. So many of these patients post-operatively, after the 3rd to 4th week, should be on some kind of a penile stretch. The stretch can be a self-manipulation. It could even be a gentle vacuum erection device so that all these things don't undergo a fibrosis which could happen around. So overall, if I look at it from a point of view of a resident, from a point of view of a clinician, we look at one thing is we need to be identifying these patients. A lot of empathy is required in any aspect of care, more so in external genitalia, because we need to counsel them very thoroughly. It's about being able to connect with the patient, talk to them thoroughly well, give them an aspect of care where you're reassuring them that this is not wrong, this can happen, and this is not uncommon. So you're not going through something. These are all important aspects of care which you miss out on our surgical training days. Thereafter, it is all about looking at a wonderful algorithm which you have shown. Those patients who have got erectile dysfunction progressive, you got to be very careful about them. Those patients who have got poor erections over the last 6 months to 2 years in a progression of Peyronie's disease should not actually be offered anything of incision and grafting alone. More counseling, waiting and watching for some more time, or as you rightly said, on the right half of your chart, giving them a possibility of a penile prosthesis, giving them a functional penis, a serviceable organ is very, very important. The challenges are when the corpora is at the tip of the corpora, if the corporal plaque is at the tip of the penis or completely at the root of the penis, or there are multiple plaques converting the penis into a J shape or an S-shaped deformity. Those are real challenges for the master. Those are where we need to look into counseling and doing a better progressive procedure where we do a penile disassembly. Otherwise, if I look into it, this was a thorough presentation towards catapulting itself into a clinical work, which is what that we all do. And we do it at Gurecon, which we all saw. Thank you so much, Dr. Shivam.
Thank you, Sanjay, for almost covering the whole topic and giving a brief idea about the whole how to evaluate and Peyronie's disease. So the important points that you stressed were that it is important to treat not the Peyronie's disease, but its ill effects of the Peyronie's disease. Secondly, how important it is to do the counseling before the treatment. Again, third part is the challenges that you can face on Peyronie's disease. particularly the complex kind of Peyronie's disease, which require complex management. And then what he missed was the intralesional injections. That is again an important part of the management. In our center, we have been doing intralesional verapamil and Hyalase injection with good results, particularly patients who are in pain. They do have almost recovery of the pain. Almost 99% of patients do recover pain which are not responding to the oral medication. And plus, they do have some degree of resolution of the curvature, which may be 10 to 30 degrees. So intralesional injection still do have a role. And we all know that the clostridial collagenase, which has come in the market as Xiaflex, is being used, but though it is not available in our country, and it is quite costly also. But anyway, the other drugs like verapamil or Hyalase or interferon, and before that, people were using steroids also, but that has come into a disrepute and it is almost now obsolete. So thank you. And if there is any query from the residents or consultant, we will take it up. Otherwise, I will just briefly summarize before we take up the MCQs, right? So for the benefit of the residents, you have all heard Dr. Sanjay Pandey, who is an expert on Peyronie's disease and other aspects of reconstructive urology. I would just briefly summarize it for the benefit of the residents. So if you go into the history of Peyronie's, it was first reported by Theodore Borgognoni in 13th century. And then it was later described by Fallopius in 15th century. And the Peyronie's disease name came by a person called Francois Gigot de la Peyronie in the year 1743, by whose name Peyronie's disease is there. When we come to the incidence, this is around 3 to 9%. So this is not an uncommon disease, though it is most common in the 5th decade of life. But again, even younger patients and the older patients can have Peyronie's disease. There are a few other names of Peyronie's like Indiratio penis plastica or von Buren's disease. There are some associated conditions which can be associated with Peyronie's. They include Galliaz's triad, where you find fibrotic nodules in the ear. There may be Dupuytren's contracture. It may be Lederhose's disease. And sometimes people with carcinoid syndrome may have Peyronie's disease. When we talk about the pathogenesis and how it develops, the basic pathology is penile trauma, which is usually a chronic small traumas, which is followed by some injury, which results in bleeding, clot formation, inflammation, and resulting in fibrosis. And this fibrosis usually will get remodeled by wound healing. In these patients who have Peyronie's disease, this remodeling of the wound healing is impaired, which results in persistence of this fibrotic plaque, and that results in Peyronie's disease. If we go into the exact pathology, whenever there is an erect penis, there is an increased pressure in the penis, and which is multiples of 100 millimeter of mercury. And that increased pressure will increase the intraluminal penile pressure, which results in delamination of the internal circular fibers of the tunica albuginea, which is the covering of the corporal bodies, at the junction of the septal fibers. And this delamination of the fibers will result in some kind of injury, resulting in bleeding, fibrosis, and resulting in plaque formation. So this is the basic pathology. Chronic microtrauma, particularly when patients have during sexual intercourse, vigorous intercourse, they result in trauma and can cause this kind of a pathology. When we talk about the history, the patient usually presents with either pain in the penis, or it may be a deformity of the penis in the form of a curvature or a hinge deformity or an hourglass deformity, sometimes a shortening of the penis, and they can complain of a difficulty of coitus, intercourse, penetration. And sometimes they may complain of erectile dysfunction. And then there are other psychological issues which come after the development of the Peyronie's disease, like anxiety, depression, etc. So when you take the history, it is again important to take the family history also, where if they have a history of some kind of a fibrotic disorder or a collagen disorder, connective tissue disorder. And you should take the duration of the symptoms, whether the onset of the symptoms, whether the pain is associated with the disease, whether they have been able to have penetrative sex or not, whether the patient has erectile dysfunction, and we should interview the partner also, whether the partner is dissatisfied or not. So all this is important in the history. When you do a physical examination, it is important to actually palpate the plaque when with the stretched penis. And if you can measure the size, and sometimes the calcified plaque can be felt as a hard kind of a plaque, which is either calcified or ossified. And then you have to also know the penile stretched length, which is important in the management of Peyronie's disease. And while investigating this patient, we should at least get a HbA1c for diabetes. As we know, diabetics have a higher preponderance of Peyronie's disease, and hypercholesterolemia, which is again associated with Peyronie's, and sometimes hypogonadism have also higher incidence. So get a serum testosterone level also. And then you can do a penile Doppler study, which will tell you about the plaque, the calcification of the plaque, the size of the plaque, and also the erectile capacity of the penis in the form of a Doppler study where you get the peak systolic velocity and then diastolic velocity. And then if you are trying to manage this patient surgically, you ask the patient to get photographs of the erect penis where you can actually see the curvature. So these are important investigations. Usually CT scan or MRI of the penis is not required unless it is a very complex case. So in the management, we all know reassurance is a very important part of the counseling, telling them that this lesion is not cancerous, this is a self-limiting disorder, and patient can continue with their coital activity. So this is reassurance is very important, as a quality of life issues are very important in Peyronie's disease. The second part of therapy is pharmacological therapy, in which the various drugs that came in, like vitamin E, colchicine, potaba, tamoxifen, PDE5 inhibitors, pentoxifylline. So most of these have not proved their relevance when we talk about evidence-based medicine. Then we have intralesional injection. Intralesional injection definitely have their role. Verapamil, hyalase, interferon, and now we know the clostridial collagenase, which comes by the name of Xiaflex. And then comes the role of surgical management. Surgical management was important if the patient cannot have a penetrative sex with the penile curvature. So usually, if the patient has a short penis or curvature which is more than 60 degrees or a complex kind of a deformity, we will go ahead with penile lengthening kind of surgery, where we incise or partially excise the scar and put a graft and straighten the penis. Otherwise, if the penis is good size, if the curvature is mild to moderate, then we can do with plication surgery, which comes in the form of Nesbitt's plication or 16-dot loose plication. If the patient has associated erectile dysfunction, which is not responding to PDE5 inhibitors, then we may have to resort to penile implants. So penile implants, again, after putting, we usually put a 3-piece inflatable penile implant, and after putting the penile implant, we will model the penis to see if the curvature goes down. The modeling is done by putting a counter pressure against the convexity and maintaining it for some time and see whether the penis gets straightened. If the penis doesn't get straightened, then you may have to make some relaxing incisions on the convex side, and that may straighten the penis. If that also doesn't help, then you incise the plaque, put a graft, and straighten the penis. And post-operatively, it's important that the patient is counseled about penile stretching using vacuum erection device or penile traction device, and sometimes PDE5 inhibitors to maintain the length of the penis and to maintain the straightness of the penis. So I think this was in a brief, the whole evaluation and management of Peyronie's disease. We would go forward with the MCQs. Yeah, so you have a question? Yes, go ahead.
Sir, the role of low-dose PDE5 inhibitors in acute stage of Peyronie's, and should we combine it with colchicine by giving in the acute phase of Peyronie's disease?
So he is saying the role of PDE5 inhibitors and colchicine in acute phase of Peyronie's disease. Yes, we have been giving colchicine with some results in the acute phase of Peyronie's disease, because surgery is only done in the stable chronic phase of Peyronie's disease. And definitely PDE5 inhibitors have also a role. So I also, yes, so if some patients who have associated erectile dysfunction, we will always combine it with PDE5 inhibitors. Even if there is no PDE5 inhibitors, you can go ahead and combine with sildenafil, which may have some role in the treatment of Peyronie's.
So how long should we wait with oral therapy before starting the injectable Peyronie's?
So usually, most of these drugs would not help in the pain management. So in the pain management, which is very important in Peyronie's disease, you need anti-inflammatory drugs. So if the patient is responding to anti-inflammatory drugs, or he is not responding, or he is requiring a long time for management of pain, in that case, we can give intralesional injection, where pain definitely subsides in most of the cases after intralesional injection. And if there is a mild curvature, that can also be helped by intralesional injection. So this is all in acute phase of the disease. Intralesional also we give in the acute phase. So if nobody has any other question, we'll go ahead. Yes, yes, Rajeev.
Patient continue with vital activity to fix or be asking.
Exactly, that's what I told in my brief kind of presentation, where I told you that the patient did not stop the coital activity. That is the part of the counseling. Coital activity can continue. So only thing is, many patients may have pain. So that pain can be taken care of by anti-inflammatory agents. And as I said, in some cases, intralesional injection. Right. So again, he didn't go into the details of the surgical management. The grafts which are usually preferred are many. So one is vein graft, venous graft, which Tom Lu was very kind of used to do. And then we have, as you said, the buccal mucosa graft also being used in many of the studies. And then we have the heterologous graft, where there could be either synthetic graft or graft, as you said, from kind of a bovine graft or even pericardial graft, and sometimes the synthetic graft. So all these grafts can be used for the management. Anybody else? Okay. So we will go ahead with the MCQs. So for the first question, Peyronie's disease is a wound healing disorder, is an autoimmune disease, is a transient disorder, may degenerate into cancer, is associated with Dupuytren's contraction in 40% of men. Yes. A. So it is a wound healing disorder. So as I said in the pathology, it's important that the remodeling of the fibrosis is at fault in patients with Peyronie's disease. So the fibrosis remains there, and because it is one of the hypotheses is autoimmune disease also, but it's not exactly an autoimmune. It's not a transient disorder. It doesn't degenerate into cancer. And Dupuytren's contracture may be associated, but not in 40%. So I think this is a wound healing disorder is the answer. The fibrous plaques in PD originates in Buck's fascia, corpora cavernosa, corpora spongiosum, tunica albuginea surrounding the corpora cavernosa, tunica albuginea surrounding the corpus spongiosum. Huh? So as I said, it is tunica albuginea surrounding the corpora cavernosa. So because there is actually, with the increased mechanical pressure, there is a delamination of the internal circular fibers of the tunica at the junction of the septum. That is why there is usually a dorsal curvature or a ventral curvature, right? Because the septa get attached at that region, dorsal and the ventral region. And the whole pathology is actually called load-induced self-amplifying oriented fibroplasia. That is, this whole pathology is because of increased load, increased mechanical pressure. And that mechanical pressure will cause some fibrosis, and the fibrosis will again depend upon the tissue stress geometry. So where exactly the stress is on the tunica albuginea. That results in the fibrotic lesion at particular areas, resulting in curvature. So the third is plaque calcification. Can be reliably identified on physical examination, can be found in 50 to 60%. Is not an indication of stable, mature disease. Is associated with successful intralesional injection therapy, is a predictive factor for the need for surgical treatment. C is not an indication for a stable, mature disease. So not necessarily, yes. So it is not necessarily a mature disease, though it used to be thought that calcification is actually tells you that the disease is mature. So C is correct. Yes. So rest of these intralesional injection will not help in calcified plaque. On physical examination, you cannot tell exactly whether this is calcification or a fibrosis. On ultrasound, definitely you can say whether there is a calcification. So penile duplex ultrasound provides information on all of the parameters except penile deformity, erectile response to vasoactive penile injection, penile vascular flow parameters, penile sensory integrity, plaque calcification. So it doesn't tell about penile sensory integrity, right? Tunica application is preferred for mild to moderate lateral curvature correction in a patient who is able to accomplish adequate erections with the assistance of PD51 because less shortening compared with grafting, better sensory protection, diminished risk of post-operative erectile dysfunction, greater potential for loss of erect length, and less chance of recurrence. So C, so there is a diminished risk of post-operative. So de novo erectile dysfunction is more common when you incise and put a graft. So that is important. Sensory protection is again could be hampered when you take plication sutures, and that can cause injury to the nerves, dorsoneurovascular bundle. So it has less shortening? No, it has more shortening than grafting. So C, right. So all of the followings are true regarding penile traction therapy after surgical penile straightening except increases or preserves post-operative length, encourages tissue remodeling, should be used for 3 or more hours a day for optimum results, increases the risk of sensory change, results appear dose-related. I think it doesn't increase the risk of sensory change. Should be D, yes. Why should it change? So usually it doesn't cause injury to the nerves by penile traction. Rest of them, yes, it helps in increasing the or preserving the post-operative length, helps in tissue remodeling. Usually you have to put it 3 or more hours a day for optimum results, and results are according to the duration for which you have been putting the penile traction. Yes. So what is the most dreaded complication occurring after manual modeling during placement of a penile prosthesis in a man with PD? Punica tear proximal, urethral injury, sensory deficit, recurrent curvature, distal urethral perforation. Can it cause urethral injury? So because usually the curvature, in 2/3 of the patient, the curvature is dorsally. So you have to make a counter pressure on the ventral side. So if you make more, there could be some urethral injury, I think. I think that could be urethral injury. Yes. So the answer is urethral injury. Most of the times, because of the dorsal curvature, you have a counter pressure on the ventral side, and that may increased excessive pressure may result in urethral injury. Indications to perform a plaque incision or partial excision and grafting include all of the following except a severe curvature, indentation resulting in an unstable penis or hinge effect, a short penis less than 9 centimeters with severe curve and poor rigidity, a short penis with severe curvature and excellent rigidity, and extensive plaque calcification associated with severe deformity. Which one? So, of course, a severe curvature requires a grafting. Extensive plaque calcification will require rather an excision and grafting. So, we are doing a kind of a technique which is called tunica sparing plaque excision, which is very beneficial in calcified plaque. Short penis with severe curvature and excellent rigidity. Yes, short penis with severe curve and poor rigidity. So with poor rigidity, you need an implant, right? So I think C should be the answer, right? C. The primary concern with a grafting procedure for PD is post-operative erectile dysfunction, incomplete correction of hinge effect, penile shortening, decreased penile sensation, and graft infection. So the major concern is erectile dysfunction. So there's a almost good incidence of de novo erectile dysfunction after grafting. Which of the following is a candidate for plaque incision and grafting? 60 degrees severe ventral curve, 30-degree curvature with suboptimal rigidity even with PDE5 inhibitors, 70 degrees with hinge effect, 90 degrees lateral curvature presenting 5 months after onset, and 30-degree dorsal curvature in a patient who desires to gain length as a result of surgery. C, 70-degree with hinge effect, or 90-degree lateral curvature with 5 months onset. So the answer is 70-degree with hinge effect, C, correct. So severe curve greater than 70 degrees and hinge effect are 2 indications to perform an incision and grafting procedure. Ventral curvatures, when repaired with grafting, have a much higher rate of complete erectile dysfunction, right? And those with suboptimal rigidity tend to also develop more erectile problems post-grafting. A 90-degree curve may be an indication, but all surgical procedures should be delayed at least 1 year from the time of onset, with 6 months of stable disease. Finally, it should be recognized that although a patient is more likely to recover some length after performing a grafting procedure, neither grafting nor plication operation should be expected to result in substantial gain of length. The primary goal is straightening. Thank you. So with this, we end the MCQs. So I would request once again, Dr. Sanjay for his last remarks. And if anybody has any other comment to make, then we will go ahead. Otherwise, we'll wind up. Sanjay, are you there with us? Or anybody who wants to make any comment, please go ahead and unmute yourself. Otherwise, I would request our moderator, Dr. Manoj, to kindly give his last remarks and wind up the session.
Thank you, Rajeev, for beautiful presentation, and thank you, our guest, Dr. Sanjay Pandey sir, for give valuable information, and thank you, Shivam sir, for the great information.
Thank you. And I thank all the residents, faculty, and all those who might have joined us today on Zoom and YouTube. Have a good day. Thank you.